and welcome to OT and Power Hour. I cannot wait to introduce my special guest today. Our topic is confidently treating male clients. And I can't believe it. I don't think in the past 2.5 years that we've been doing OT and Power Hours that we have talked about this yet. So the time has come. And Sujata, I am so excited that I'm having this conversation with you today.
Yes, likewise, Lindsey. And like you recognize, we just don't talk about it enough. And I am personally a person who used to only treat people who were female or people with uteruses. And I transitioned slowly, and I recognize that was a very conscious choice that I had to make specifically. And I hope this conversation is helpful and offers some good, helpful insight to everyone who watches.
Excellent. So I always kick these things off with an icebreaker question, which I will do that with you, Sujata. I will invite everyone joining us live to please put it in the comments as well. Then I'm going to share a brief introduction to you, and then we'll kick off this well-needed conversation.
Sounds wonderful.
So my question for you, Sujata, is if you had to use a fictitious name, what name would you use?
That is so interesting. Oh my gosh, like in my professional life or
I would imagine, I'm thinking like, you're a character in a novel, and you're a character in a novel. What would your fictitious name be?
Oh my gosh, I could have I don't know. I grew up with Agatha Christie novels, and if I had to be a fictional book character, I would have to be a detective. So who knows, Agatha something.
I love it. I'm going to put down detective for you. And if you come up with another name, or like a specific name, because I don't usually share my icebreaker questions with people before they join. So Sujata was totally on the spot. So if you come up with a name, I'm going to put detective because I love that. And I love knowing that background about you with reading Agatha Christie novels. I think that's so cool. I'm in the same boat. I put the name Veronica down. It was a family name. So that's kind of my fun little fictitious name, but we want to hear what you have to say. And if you're on replay, we love hearing this too. It also gives us some information that you're here, and it jazzes Sujata and I up to know that you're joining us, whether it's live or replay.
Yeah.
Okay. So I want to share a little bit about Sujata. She is a pelvic health occupational therapist. She specializes in fertility, birth preparation, and complex pain management for people of all genders. She helps her clients heal through a highly specialized approach, which combines conventional pelvic rehab with osteopathic manipulation techniques, Ayurveda, and an integrative mind, body, soul approach. Outside of the office, you'll catch her at a yoga class or walking Tampa Bay's trails with her family. Sujata, I'm so happy you're here.
Thank you. Likewise.
All right, so let's get into it. I, of course, have a bunch of questions for you, but as always, if you're joining us, please throw your questions in the comments, whether it's live or replay. Sujata is a really active member of our group, so I'm sure she'll see the questions. So my first one is, you kind of explained to us a little bit about this transition where you first started off working with people with uteruses, and you conscientiously made this transition. What was happening that kind of led you there?
Yeah, that is very, very important conversation to have. And I was thinking about today's topic, and I realized that it is a little one-sided, meaning I'm talking about therapists who identify as female or women treating men per se. And I'm not aware of any male pelvic OTs, because I'm sure that conversation when the roles are reversed, when it's a male therapist treating a female client with pelvic health, it's going to involve a similar dilemma. But speaking largely to our group, where me as a cis het female treating women and people with uteruses, the transition was easy, meaning easier going from a conventional rehab setting from like SNF or outpatient where we are working with people clothed, meaning it is not a very intimate treatment setting, right? We are not expecting our clients to undress in front of us and also expose a part of themselves that they haven't to accept their intimate partners or only specific medical professional maybe once a whole year. And there is this expectation when they come to pelvic therapy that we interact with this part of someone's body that is so private to them. So like most other people who are pelvic OTs, who seem to be, again, women and people with uteruses, the transition to only treating women and people with uteruses was just natural. Like I felt most comfortable interacting with that anatomy, and there didn't seem to be as many awkwardnesses I had to get over. The language just came simpler. And also just the way trainings are structured in that most introductory trainings, and I am not taken OT pioneers, so I'm not sure if you go over male and female anatomy both in your first introductory course, but most other, like I had taken like MedBridge and things like that, they typically focus on female anatomy. And that makes sense in a way because pelvic dysfunction is a predominantly female or people with uterus problem just because of the life cycle of individuals with uteruses. So just because of the training I took and also my own gender identity and sexual orientation, I just felt comfortable treating women first. And just like anything else, as we grow in skills and we grow in confidence, I felt more comfortable taking courses that addressed anatomy that was different from mine. So the transition, it took at least a year and a half. I know a lot of therapists choose never to transition to treating people with different anatomy than theirs. And I understand that, meaning I also come with a very clean slate. I am very stupidly lucky in that way, meaning I have never been exposed to traumatic situations sexually, emotionally, where being exposed to male genitalia or even a man in a private treatment setting without someone present there would not put my nervous system on edge because I just don't have that history. So I recognize that I can be in my balanced, rational, clinical mind while treating someone who doesn't share my genitalia. Now, that could be different for someone else. So I totally recognize why some therapists, and I'm not saying trauma is the only reason that why some therapists would choose only to treat women or people with uteruses. There are plentiful reasons, but that was just one thing to recognize, that if you are someone who has survived trauma, whether it is sexual, emotional, verbal, physical, of course, that you may have to do some more work on your own end before you can help someone who doesn't share your anatomy. That is just one thing. We have to recognize what we carry and if we can be fully present for that person, because even the most non-threatening, the most respectful individual without the same genitalia as you, meaning a male individual or someone even transgender but having external male genitalia, they may bring about emotions or nervous system states where you cannot use your clinical skills fully. So recognizing that, okay, where am I right now? Can I take this on is, I think, step one in deciding to make that transition. There are, of course, other things like I know I am still in a very happy marriage with a man and a heterosexual relationship. And initially my partner, my husband, was like, I don't feel comfortable with you treating men, and which I completely understand where he was coming from, because in the beginning I used to do concierge care, meaning I would be in people's homes. And honestly, I did not feel comfortable going to a man's house and having that individual be undressed in such a private setting. So at that time, when I did not have a clinical space where there were other professionals or people in that treatment area to ensure my physical and emotional safety, I chose not to treat men. When that transition happened, that, okay, I am in a clinical setting, whether in a physician's office or in just like in a bigger office building as today, where next door, if something were to happen, God forbid, there was someone who I could turn to for assistance, I feel comfortable inviting in men and people with penises into my treatment space, right? So we have to think of more practical things like logistics, and even practical things like, again, your relationship. Like if you have intimate relationships, what is your intimate partner's take on that? Ideally, again, your partner would be supportive of your choices. If you feel ready in other ways, your partner would support your decision to treat who you want to treat. But again, that's a conversation you need to have. And it should not be, oh, my partner is not very comfortable, but I'm doing it anyway. That's just setting yourself up for, a poor relationship, not just personally, but professionally, because you will have hesitations then. Being completely open and asking questions about the individual sexuality, what their sexual performance is like, doing actual physical exams on male genitalia, or so again, just I think those are the three big things: recognizing your own any traumas, what your nervous system state is like when interacting with people who don't share your anatomy, understanding logistically, would you feel comfortable emotionally and physically inviting people who are male or people with penises into your space? And again, from an interpersonal point of view, is this something that you feel fully supported in? And for me, the turning point happened when I recognized as I would get inquiries from people who were in very hard places, meaning people with very significant pain, and they can't find anyone, or they have tried a different therapist and they are looking for a new approach. They have heard of what the work I do, and they really want, it felt really bad turning them away. So again, I recognize that. And that's the same thing. A lot of us in this group watching probably feel that way, that we want to help, but we are fully not in that place. Then honestly, it's like always make yourself comfortable. You always have to first respect your boundaries and your needs, because if your needs and boundaries are not met, you cannot take care of someone else. That just leads to more ethically confusing situations. So I did turn away people for a while till I was again, okay, I feel fully okay being in this treatment situation, is when I began treating men, and it has been wonderful. On a lot of therapy networking groups, on the OT group, there's other PT groups and such. There are often questions about men saying inappropriate things or inappropriate situations. And again, it sounds like victim blaming. I'm not going to say that, but again, you need to have a script in a way of, if something happens, how you handle that. And if you are again firm, and that's again coming back to boundaries, right? You recognize your boundary. Anyone comes close to stepping through it or out of it, we're like, okay, we are done here. That needs to be a conversation had without any guilt or any, placing of judgment. And then you can successfully treat men, confidently treat men. I enjoy treating men sometimes because they are so glad to find someone who can treat them, and they don't feel embarrassed. They don't feel embarrassed asking questions. Sadly, there aren't enough male therapists doing this. It would be lovely if there were more male therapists and therapists with penises treating this population, but there just isn't. So it's very refreshing for the patients also to find a female therapist who doesn't have, who can have these conversations without hesitations, without embarrassment.
Sujata, there's so much there that you said that I would love to spend a whole nother 6-part series of an OT Empower Hour on. So thank you so much for all of that. The one thing in particular that's really resonating with me right now that I'd love to mention is this idea of asking ourselves as pelvic floor OTs, where am I now?
Mm-hmm.
So you put this in context of working with specific anatomy or specific community members, but really it's a beautiful question to stand back and ask ourselves with anything. I mean, that's just a beautiful philosophy. And in the beginning, perhaps when we're seeing clients, it's really easy to put our needs aside and just have this desire to see and help and serve everyone. If we're building a business, oh my goodness, why would I say no to anyone? Yeah. This is something I'm forging forward and building and growing. But the thing is that sometimes, and this happened to me in my own practice in New York City, where I did hit a brick wall, where my body was starting to hurt because I was doing concierge service on the floor, not caring for myself, just being so client-centered. And I think that what you're bringing up is so beautiful, because it's this intermediate/advanced topics that I think we should be bringing to the table in an even introductory setting, so that we can know where things may be headed and take them into account now. And so again, coming back to this question of where am I right now, where is my nervous system in this situation on this day, is so incredibly important. So thank you for bringing that up and for weaving it into today's topic.
Yeah, of course. And that's
So
just the thing, we want to take care of our patients, but if we are not taking care of our needs, we are not 100% present. And then they are getting subpar care. Like you're not at your best. They're not
that's
getting
right.
your best,
That's right. It doesn't serve anyone. It doesn't serve them, and it certainly isn't serving our family or ourselves. So thank you for bringing all that up. I'd love to hear a little bit about what a typical session may be with your male clientele. I've definitely heard from some of my students that, they just kind of can't imagine things, even to the idea of like robing and draping, so
Yeah.
so would you mind walking us through so that it can become really clear for those of us who haven't actually treated males before what that looks like?
Yes, of course. So in a typical session where I have never met the person before, I do try and take a peek at their intake so I know a little bit of what to expect before the person has walked in. But when they walk in, just like any other patient, I would start, of course, with asking their history, what's going on, what their primary concerns are. I also make it very clear initially that I try and explain what a pelvic exam looks like. I also say this to my patients that, which has been true in my practice, may not be true in others. I tell them that for most of my male patients, they are not comfortable with me doing a rectal exam day one when they are not familiar with me, when they don't trust me yet, because that is also my treatment philosophy is I never like push my way into anyone's body, be it their abdomen, their neck, their pelvis, wherever. The body has to be accepting of our approach. Otherwise, we are just causing more barriers that later have to be broken down, right? So I say that, you might have heard, or I ask them, what are you expecting? And then I would say that, okay, they have a fair idea of what pelvic floor therapy is or what they expect from today's session. And I say that, okay, if you have gotten pelvic care before, or if you are comfortable with rectal insertion, we can definitely try and prioritize or try and get to that today during our first session. But in most cases, I start my male clients off with, there is so much we can do outside the pelvis, right? We start off with all of that. And I tell them I will start doing hands-on care. And this is also maybe just how I treat. I do a lot of manual work on the abdominal wall. I do a lot of manual work on the external pelvis. And then when you are comfortable with me, when you know what to expect, the intrapelvic work will be that much more comfortable. And I also say this, like if we talk about the fear, tension, pain cycle, right? Like if you are apprehensive, if you are fearful, your muscles are going to tense up. And then the internal exam will only tell me what your pelvic muscles do in a state of tension. The pelvic exam will not tell me what your pelvic muscles do normally at rest. So it's not a true good assessment. I would rather you be in a relaxed state where I get a better picture of what your pelvic muscles do at rest, at baseline. And therefore, sometimes let's hold off on it till we meet again. But we go by the patient's preference. If they are still like, nope, let's just get to it because finally I have someone who can answer my questions, then we go for it and we cue the person through the exam. As far as robing, because I know you mentioned that, so I'm in a setting where, first of all, honestly, every pelvic therapy practice, you should have a dedicated room with a door that closes, no screens, please. You cannot expect people to be comfortable with just a screen separating them from any other areas. So that's a setting I have, the doors behind me. So when I am ready to proceed to the hands-on piece of the assessment, I will hand my patients a couple things. I will hand them like a soft, flexible chalk pad. I will have a chalk pad placed out just like any other pelvic exam. They will have a disposable drape to cover the bottom half of their body. So basically the same setup like a female patient, except they get an extra chalk pad to cover their genitalia. Unless I am treating someone who truly has trauma to the penis or an injury to the penis, where I'm suspecting there is scarring on it, I do not work with the genitals. And I tell them this, that I am a pelvic floor therapist. I am treating with the pelvic floor muscles that are inside and outside your actual bony pelvis. I do not need to manipulate your penis. I do not need to manipulate your scrotum. So you are going to help me by covering. So I have them open up the drape and they basically sling things out of the way when I need to access the perineum. So I explained that this is just to cover yourself. You're going to drape it over your front half. and you will then move it out of the way. When I work in the right side of your groin, you're going to take one hand and scoop everything out to the left side. When I work on the left side, you will scoop everything off to the right side. And when it comes, and that's because I always start in the groin and, clear those areas first. And when it's time to go internally, and this I will talk them through, it becomes overwhelming, right? We don't want to load them with instructions. So before walking out of the room to have them undress, I just give them, I have already placed a chalk pad out and I just say, this is to cover your genitals, because we are not going to manipulate your penis or scrotum. The problem is not there. The problem is in the pelvic muscles, which we have established by then. And when I come back and we are walking towards the internal part of the exam is when I will ask them about moving the parts away to give me clearer access.
That's so well explained, so articulate. And I think that it's for those of us who are unsure even what that part would be like, hearing that explanation demystifies it so much. I also really love that you, when you're talking with your clients, you say, what are you expecting? I think that's important because it starts to put us both on a common ground of expectation setting. It's an open-ended question they could interpret many different ways, and very often where they choose to go highlights some importance to them. And I also, along those same lines, I love to present a menu of options to my clients regarding ways that we can do that exam, right? It can be external, close on, it can be external, close off, it can be internal, and presenting them that they're all equal. There's not a hierarchy, there's not a gold standard. And this really also helps that nervous system to recognize that, number one, they have the choice, right? And that we can ease into things. And so I also love that you are putting hands on other parts of the body, because you're right. What's the value of an internal exam with tension? They probably have tension, but we're seeing so much more when that comfort isn't there. Sujata, we do have a question coming in from Usha. She is wondering, how do you identify or recognize red flags?
So again, honestly, just go with your gut. If something is making you uncomfortable, that's the thing, right? Nothing is a secret, meaning to truly help your patient, they have to be transparent with you and you have to be transparent with them. That's a great question. So if something makes you uncomfortable, say so. So I will also, when I'm getting close to doing work on the pubic area or in the groin, I will say that, first of all, you have to help me by moving the genitals out of the way. I don't need to work on them. It's not going to help you. But also by working on this area, you may experience increased blood flow. We may experience somewhat of an erection. If that happens, I am going to withdraw my hands. I'm going to let it subside. If I need to, I will leave the room and I will re-enter the room when you are ready for me. We do not, and there have been like posts in social media groups about like predatory people who unfortunately try to take advantage of therapists. And so that is very clear. I've had phone conversations with similar people. I've not had anyone in my treatment space because I always interview someone before they come in. Because honestly, it's as much an interview of them as of me, right? I want them to be a good fit for me. So I make it very clear that no, we cannot allow ejaculation within the treatment space. If you are having issues, like, yes, I can have you take care of that. Or if you need to, like if you have PE and you feel it's coming, I will step out. I will leave the wipes for you so you can clean up and then I'll re-enter the space. But, and I also say, because not everyone is a predator. That's the first thing. A lot of people come with true pain, embarrassment, a lot of shame, all of that. So I recognize and I say that. So if you have an erection, that's okay. Do not be embarrassed. It happens. I'm just going to give a couple minutes for that to subside before we proceed. So trust your gut and also set boundaries before you have to make it a thing, So again, being clear on your boundaries is a big, big thing for me, because then it's like, oh, we had this conversation before. So it's not a conversation you need to have when there is that boundary transgression that seems to have happened. So yes, we are very clear that erections are okay. I will never stimulate anyone's penis. No one can stimulate their penis when they are with me. That is not acceptable. That will not happen here. And that's the thing. This is my space. And it doesn't matter if you're insurance-based, cash-based. That is a transgression that is not allowable. It's no longer a medical service. You are discharged. And you can say that, this is not a medically necessary service. You can choose to do this elsewhere. I will have to discharge you. So, and some people make compromises. Well, I have a chaperone. Like, why? That is no longer medically necessary. This person, if they are choosing to kind of play with boundaries, they're not coming with a medical need at that point. Yes, they have needs, maybe more with like a psychotherapist at that point, but not with a pelvic health therapist. So do not bend over backwards trying to accommodate someone because A, they are on your schedule for whatever reason, be it your cash based or insurance based. And if someone, again, that has never happened to me, I have thought of it, what I will do. If someone comes here and something happened, like, you are done, you have to leave, this is not acceptable, they don't get a refund, like, you wasted my time. That is how I see it. So again, respect your boundaries, because if you're not comfortable, you cannot give good care. And your boundaries matter as much, like your comfort matters as much as the patient's, just because someone has bought your time, they have in a way, whether you are cash based or insurance based, does not give them the power over you to make you uncomfortable.
That's so well said. Thank you for saying that. Sujata, I know we only have a few minutes left because you have a client that's coming in shortly. Tell me something that you love about working with this clientele. Like what's one of your favorite aspects about it?
I really love that, again, sometimes, and I think it's just because there aren't enough people doing it, when they come in, they are so motivated. And sadly, it's a tell on society, meaning when your average mother comes in, she is trying to juggle home and kids and with her recovery. So recovery is slower, whereas men are so preoccupied with their genitals that they will give you 100%.
It's so true.
They're like, I will do my exercises every day of the week. I'm like, every day is not necessary. Like 3 to 5 times is good enough. Like, I'll do it every day. I'm like, okay. So they are fabulous patients, meaning they are great. I have someone who brings me lunch all the time. He's in the most nice way. He's like, oh, I thought you'd be hungry. Here's lunch. I'm like, that is so wonderful. Because he's like, finally, someone's helping me with his, helping him with his problem. So just that male patients can be very, very dedicated. At the same time, again, I truly understand the difficulties some female, especially younger female therapists, they may get inappropriate comments. They themselves may not be comfortable. Then do not treat that population if you're not comfortable. Or again, have a chaperone. But again, that would just be my bottom line is, while trying to provide patient care, do not allow your boundaries to be transgressed. Do not allow yourself to be uncomfortable, because it will put you off of providing much needed care. Because of 1 out of 10 patients who is pushing a boundary with you, 9 patients in the future will not receive your life-changing care.
Exactly.
So really, yes, it may seem like a difficult conversation to have, but that difficult conversation is providing much needed life-altering care to like 9 other people. So it's really like we are doing our patients good by being firm and kind, and you say it with a smile. So you rehearse it, but you say it nicely, you say it firmly, and it doesn't have to be a big spiel, right? But start off with those good boundaries, and you're setting yourself up for a good track record of treating people with other genitalia than yours. And you are setting yourself up to not have these ethically muddy waters, to navigate.
Yeah, so beautifully said. My experience as well, Sujata, mirrors yours in the sense that I have not had any challenging situations, which I feel really lucky about, but I did think deeply first about my boundaries and what I would say so that I would feel more comfortable offering services. And I have to agree with you. They are so in it. Like, they are motivated. It is clear cut. It is straightforward. So anyone on the fence, I hope today's conversation helped you think of it from different ways. And perhaps if there were hesitations about treating this clientele, Sujata aired them today and gave some really concrete ways around kind of getting through, or at least considering from different angles, the ways that you can handle some of the things that potentially could make us uncomfortable around treating someone that has a different genitalia than us. Thank you so much, Sujata. I know you have a client that's waiting for you. I'm so grateful for our time today. You spoke with such clarity and such passion, and really grateful to have you in our community.
Oh, thank you, Lindsey. It has been a pleasure. And I hope this motivates OTs, other OTs to treat this population, because it can be so wonderful. Again, for every horror story, there's like 100 great stories out there. And we are not just changing that one person's life, we are making ripple effects, in society in a way. So I hope this was helpful, and I'm so glad to be here. Thank you for having me.
Rebecca says, thank you. Carolyn is here. She says, thank you. Lexi's here. She says, thank you. It was fantastic, Sujata. Have a beautiful day. I can't wait to see you all next week for the next OT and Power Hour. I appreciate your time so much.
Thank you so much. Bye-bye.